started. I'd like to thank the organizers for invitation, and it's a difficult task for me now, after Philip and Peter, one of the big promoters of the Melody valve, to give you an idea about perhaps is there another valve that may be as good or even better as the valve we have seen now in thousands of cases. So my task is to present you a little bit data about the DHZB valves. So that's the next one. So these are my usual disclosures. If a company is missing, please tell me. I'd like to highlight that there are new guidelines for the replacement of valves, which are published just recently. Where's the pointer? No, it's not a pointer. We have another pointer. Here's a pointer. Which have been published recently in the Cardiology and the Young in 2017, where you find quite nice and really elaborate guidelines about pulmonic stenosis as well as pulmonary regurgitation. So where did it all start? The first pulmonic advantage of SAPIEN was the DHZB valve with the 23 and 26 millimeter diameter. It was made like the Melody valve to promote the lifetime of conduits and to basically deal for valve conduits. So that's the idea. A conduit is the thing where you can implant this only. The first case, a young case in 2006 in the US, DHZB, he could persuade the company to provide on a compassionate care basis the valve for the first patient. Then they had the next paper, so they put these first patients together, 7 patients in 2010. So a little bit more experience, but the same patients. And last but not least, we had the first, after the CE mark, which the team here, sitting here in the audience, implanted the first Edwards CE marked valve in a patient here in Germany. And mind you, that's the important thing. You have to get it really round with all the pre-stenting, so these valves work quite well. From that on, in 2011, we had the first more larger studies, 36 patients, and you see all the typical things you find in all the publications. The RV pressure goes down, the gradient goes away, and the pulmonary regurgitation fades away. And you see this here, so that's the pressure, and this is the regurgitation before and afterwards. So these valves do work. So that's a basic, simple story. What came next from Germany and from other countries where we did some let's say, more local evaluation. The first in 2012, the first 22 patients, a multinational study again. Again, you see gradients fade away, incompetence fades away. But what we have been able to show there, if you look at these numbers, we were able to show that there have been conduits as well as non-conduit patients, so we could extend the use. And we were using very, very small conduits from 8 times 9 millimeter diameter, and we could increase by stenting these diameters up to 24 millimeters, etc. So it's not only the big surrounding vessel which you can treat, you can also tackle smaller vessels and those without transannular patches. And again, here you see the regurgitation which fades away. Then Edwards made some more developments, and basically driven by the development on the aortic side. So the big brother, it's the aortic valve, and the small, tiny little brother, the nice-to-have thing is the pulmonic valve in these companies. Like in the Medtronic company, I presume the same. So next step was the XT, which came in 23, 26, and 29 millimeters. And then the instruction for you to say, well, you can use it for non-compliant right ventricular outflow tract. So it's a little bit extension of the whole idea. And nowadays, we, in most centers which I know, do treat patients not with the XT valve, but off-limits, off-label, with the SAPIEN S3 valve. Why is that the case? Because that's the valve which is in the shelf of the adult guys, and you just go there and you need a valve to take the valve from the shelf from the adult guys. And so these are the valves available, so 20, 23, 26, and 29 millimeters. So the question, though, is, how big should the first valve be which you put in? And having seen from our first speakers that you start with a valve and then you have the idea of putting the valve in valve further down the track. So this is what will follow. So basically you start with a big valve and then you put the next valve, the smaller one, inside. So then it's what is normal. We all have to know what is normal from our data. And if you look, the topic here is the freeway to the lung, the right ventricular outflow tract, the pulmonic valve. How big is the normal right ventricular outflow tract? So here you see 665 healthy children, and basically the normal outflow tract from this is, age, the youngsters, 15 to 20 years, is something about 3 centimeters. So normal size is 3 centimeters. So how big is a pulmonic valve? How big is that? If you take data from the Framingham study, 706 patients where they had CT scans, and they just measured the CT scans in order to find out what are normal values for pulmonic valves. Again, if you look at these data, the normal pulmonary artery is about 26. So RVOT 30, pulmonary artery 26. And you can line this up in men and women in different of age and size, etc., etc. So what we tend to do is when we want to make it normal, which by definition could be the ideal way of how to treat an outflow tract, we should think of something bigger. So that's why we think, okay, this is the 20 millimeter valve, but these 23, 26, 29, so this is basically the normal size we may tackle and we may achieve. So if you have this idea in your mind and you can make one valve and the other valves, so that might be the way to go if you implant valves and you want to really expand the lifetime of your conduit. The other thing which came into the development, so if you see the valves, the Sapien XT and the Sapien 3, the introducer sheath came down quite nicely because it's designed for aortic and you want not to damage these calcified vessels of the old or elderly people. So the introducer sheath for the Sapien 3 valve is a 14 French or 16 French sheath only. And this is a size we are used to use in even the small children without any problems on the venous side. So what were the, let's say, results? The Toronto experience, and Lee Benson you see in the audience, they put together their Sapien experience. Basically, they compared the available data, the US from Kenny, the multicenter trial, our publication from Boone and the others, and basically put this all together, and then they compared their results from their patients, 75 patients. Again, they put it in a 23 millimeter conduit, and you see all the size of valves have been used, and etc. So the technique works in many, many patients reported so far. And you see the size was 8 millimeter, 23 millimeter at 8, so the bigger sizes were the sizes the more likely to be used. And the results, again, the RV pressure goes down, the gradient goes down, and the rate of pulmonary incompetence fades away over time. So these valves do work quite nicely. And the conclusion was, well, these valves have a diameter up to 29 millimeters, which affords a treatment of patients with the larger outflow tracts. And these are the patients who had a transannular patch and have these large outflow tracts, and which we have to deal with. If you compare these data now to other data, and I just took out, we have seen wonderful data from Peter Evert now, and I just took a comparable study because it's the same team, the Lee Benson team from Canada, who used this and looked at their follow-up. And here you see the gradients, and you see the amount of RV2PA gradient, etc. So this is pretty stable data. And the amount of incompetence for the melody valves now is the same, which we have seen now. But if you compare these two, well, you have follow-up is 4 years, is 3.5 years, round about the same range. Endocarditis, and we'll tackle that in a second again. There's yes in the melody and none in the Sapiens. Freedom from reintervention, 87, 63%, 96, 96%. So, well, you can even think, well, in the same team, there may be a trend of benefit towards the Edwards valve. What have we done when I was in Badenhausen? We looked at our own experience. We tried to compare as an internal standard what are the results in our center. And we didn't look only about the pulmonic valves. We took all the patients in our 6-year period who had any form of pulmonic valve. So basically, over a 6-year time, all patients, surgical as well as interventional patients who had a valve implanted. And we analyzed the patient characteristics, and we followed all these patients up during this time period, specifically with the analysis of the incidence of endocarditis. And endocarditis in our patients was not only the vague idea there may be an endocarditis because the patient had fever and we gave 4 weeks of antibiotics and everything faded away. These patients were patients when we had an endocarditis diagnosed by positive blood cultures plus a change in the conduit, so stenosis, mainly stenosis or incompetence, which was basically new and has not been there at the last follow-up before. What we found, basically we had 246 patients, surgical patients 166, some of them many homographs, 50 homographs, 100 contiguous and some Hancock bioprosthesis. We had 80 PPVI patients, 29 melodies, 51 Edwards, Sapien, Sapien XT, and Sapien 3. The treatment for all these patients in our institution was the same. So all the patients, maybe surgical as well as interventional, had the valve implanted. Then they had a 5-day course of IV antibiotics, which basically was the second-generation cephalosporin, and they were treated with aspirin for 1 year. So this is pretty standardized treatment for all these patients, all the same. You can discuss why we did this, but that's a different topic. So what were the results? In the homographs, 55 homographs, we had a follow-up of 137 patient years. We had no endocarditis. You cannot really make a statistics about this. The contagious, we had 106 patients with contagious. There were all these truncus patients as newborns, so all of them together. We had 331 patient follow-up years, and we had 5 patients out of them which had endocarditis, which is a 4.7% rate. And the risk per patient year is 1.5%, which is the same which we have just seen here in our presentation before. The melody valves, well, this was our surprise. 29 patients. We had 6 out of them had endocarditis, positive blood cultures, change in the physiology of the conduit, which basically gives us a risk per patient year of 5%. The Edwards valve, 51, no endocarditis, and the Hancock also no endocarditis. So if you put this together, Kaplan-Meier curves, the yellow one, sorry for the color, is the melody, and all the rest, sapien, etc., is up here. And these are the figures. So what was our conclusion in our center at this time? We said, well, okay, we found, this is, to our knowledge, the first study where all the valves have been included in one center. So it's not, we compare our percutaneous valves versus reported studies of surgeons, so we put all this together. I think we had a really comparable number of different biological valves. We had a uniform treatment. We could find an increased risk of endocarditis in the surgical Contega versus the homograft. We could also find a risk increasement of the bacterial endocarditis in the melody versus the Edwards, which then gives us the idea that there may be an increased risk of this biological substrate, this bovine jugular graft, which is the same in these two, versus the others. And our consequence was basically we've changed the practice there. We didn't use the melody anymore. We changed for the Edwards, which gave us also the possibility to use smaller sheaths, which was then feasible in smaller children. Yes, it's only a single center study. Yes, it's a short follow-up, but these were the results what we have used. What do other people tell us? And that's the group from Jérôme Petit from Paris, and they had basically the same idea, the same feeling, and they published there, and you've just seen the figures just beforehand from Peter in 2017, and they looked at their results too. What they found up, 33 melodies, 47 sapiens. Infective endocarditis, well, 25% in the melody and 0% in the sapien group. Just an idea, well, there are other centers who may have had the same problems, but I think the two studies, our study as well as the Paris study, we have reasonable comparable numbers from both sides. And I think we can skip this. So you see these the sapien valves and these are the melody valves, so all have, the melodies are worse in the long-term follow-up. So what was new? Well, apparently they said, if you look compare these valves, if you look at the risk of infective endocarditis, it may be that for the sapien, it may be better. Well, if you then look, is this really just our idea or their idea, or is there any other hints that you can compare this? And there's a systematic review, also published in 2017. And I think we have had these pictures from Ina Michel-Benke this morning. They looked at these bovine jugular vein valves, all of them, compared to other valve types. And melodies, contegas, homographs, not really big numbers, but nevertheless, you have these endocarditis cases, and I think that's the important pictures. This is contegra, the blue ones, and this is the non-contegra. Apparently, the risk of endocarditis in this biological substrate seems to be higher as compared to the other valves. And here you see all other valves together, and you see the risk of the bovine jugular grafts and the contegra and the melody. And basically, you put all these together, and in all these subgroups, the risk of endocarditis is higher for the melodies. And they say, putting all this together, that's what I said, there may be a higher risk of endocarditis. What about other information we have about the Edwards valves? Not only to look at comparison. There are a couple of trials. There's the Compassion trial, 7 US centers, the Compassion XT trial, which is not recruited in the US, there's the Compassion S3 trial, which should come in the future. There are non-US registries, which is the Edwards sapien trial, 127 patients, the pulmonic XT 49, and the pulmonic S3 trial, and Peter Ebert as well as I, we are involved in all these trials. One result which I can show you is the follow-up of the Premier trial for the Edwards valve. Basically, I think it's 126 patients, and you see, as you did expect from other valves, you see that the regurgitation, which has been free here, goes down, keeps quite nicely, good results over the year, mild, moderate trace here. The RV pressures go down, the gradient goes down too. So that's what we expect from all these valves. And mortality is 0, and device performance is quite good. The pulmonic XT, again, many people together, and that's what you need. You need many centers, 20 valves here, 5 valves here, to put them all together. So the idea is these 42 valves. Again, we have the valves implanted here. You have the balloon dilation here. So this is what you usually report in these centers. And the pulmonary regurgitation fades away. So there's no severe pulmonary regurgitation in the follow-up, and the gradients get better. So in my personal experience, what has changed over the time when we have now the different generations of the valves, the SAPIEN, the XT, and the S3? From 2011 to 2013, I mainly used the SAPIEN in 24 patients. From 2013 to 16, the Edwards, and since 2015, the S3. One thing is that we tend to go bigger in these valves. We get more of the larger RVOTs, maybe a little bit more experience. The mean age and weight, however, came down. With the S3, with a smaller sheath, we were using in younger kids, and we're using kids up to 15 kilograms now quite nicely with the SAPIEN S3 for 26 or even 29 millimeter valves without any problems, because the introducer sheath is so nice. And we are treating more complex patients. Patients with single pulmonary artery, redo melodies, 2 have been treated by Philip beforehand, both transjugular, both had occlusion of the right internal jugular vein, so maybe the long, big introducer sheath may be a problem. Left jugular vein via Glenn, and less than 20 kilo, 5 patients. So we're getting more aggressive, more experience, and we can do this because the introducer sheath is less. So putting all this together, I think with the Edwards valve, you have an extremely wide range of sizes available. This is suitable for more patients, even for large RVOTs. And mind you, the pulmonic program is just the small little child of the big adult problem. And in Edwards, they have around about 200,000 SAPIEN valves implanted worldwide. So that's a big number, and we do have a good experience with these valves. I think the risk of endocarditis is lower. Still, there are some very large RVOTs not treatable. And I think the smaller sheath size gives you an idea about the smaller, that you can treat patients smaller. Now, to summarize this a little bit, if you look at evolution, and at the end there is the Homo sapiens. So you start with this, and at the end there's the Edwards sapiens valve. So that's an idea what you can have. If you look in more technical ideas, well, this is the valve, and it's a good valve. It works quite nice, like these cars work quite nice. But coming from Bavaria now, I think with the Edwards valve, you have made a step forward, and with the XT even more, and with the S3 valve, I think you have a very good valve performing quite nicely. And coming now to my final slide, if you continue this, Shaq, that's now for you because you're the next speaker, evolution goes on. You can evolute like this, and that's the venous P valve where we go now. Thank you very much for listening.